different types of crush injuries and syndrome. So crush injury will end up causing basically it has the potential to cause the three things underneath of it. So crush injury is a direct injury resulting from the crush, right? But a crush syndrome, anytime that we are talking about a syndrome is a collection of symptoms. So what would a crush syndrome look like? Well, what are the symptoms of something that has been crushed? What is compartment syndrome? Again, we are looking at the collection of symptoms, and now we are calling it a syndrome. That is all a syndrome is. So when we look at these three things, we'll kind of dive into each one of them a little bit more in depth. But crush syndrome, compartment syndrome, and then another one called traumatic asphyxia. And those are actually pretty easily identified, even in the pre-hospital world, because the patients present pretty uniquely. So compartment anatomy, so this is a cross-section of an extremity, a lower extremity, and I know that because here's the tibia, and then down here in this area, you can kind of see the os there. That is your fibula bone. So here's the tibia, here's your fibula, and then you have different muscle tissues, et cetera. And you can see some areas and some openings where vessels were previously at. So compartment anatomy, intracompartmental pressures of 40 millimeters of mercury for 8 hours can cause that. Think about that. So obviously this is intracompartment, right? But if you put a blood pressure cuff on your arm and you just dialed it up to 40, it is that amount of pressure that you're feeling. Now, we know that that is external and not intracompartmental, but I want you to understand it does not take a tremendous amount of pressure for an individual to develop a compartment syndrome. The compartment itself can reach pressures as high as 240 millimeters of mercury. That is insanely high. Again, do the same thing. Put your blood pressure cuff on, dial it up to 240, and see how long that feels good on your arm, even as an external pressure. So these pressures, they will continue to exert, and they're able to do that because they'll start to collapse veins and arteries. They'll get into some of the lymphatic area. They'll start pushing the fat tissue out. So obviously this is going to end up becoming very swollen, but it has the ability to expand enough to take on 240 millimeters of mercury of pressure. So kind of an interesting thing. That's a cross section and kind of what it will look like. So what about compartment syndrome? Well, any condition that leads to a nerve or tendon being constricted within a space can lead to compartment syndrome. So an individual, and it does not have to be an entrapment. It doesn't have to be that somebody was digging a ditch and they didn't have appropriate walls up. It can happen pretty easily. We had a situation years ago where an individual had passed out, and his arm was up and over like the bottom rail of a kitchen chair. And he was there for who knows how long, hours, maybe even days. We don't really know. But his arm was not even compressed circumferentially. It was just on the bottom portion. And he ended up developing a compartment syndrome and actually became very acidotic and ended up dying. I don't know if it was exactly from the compartment injury that was the cause of his death, but he did not have a favorable outcome. And his arm was just simply laying over the arm, the rail of one of the kitchen chairs. So it can happen, and it doesn't have to be necessarily a traumatic type of event. So what happens here is the deep tissue that results in restriction of outward swelling causes that blood and other constituent parts to basically be housed inside of that muscle and inside of that compartment. And that's what causes those pressures to elevate. There's really nowhere for them to go. So under normal conditions, a normal pressure, if we were to actually measure the pressures inside of one of your extremities, it should be 0 really, but it may be up to 10. An elevated pressure is going to be anything considered over 20 millimeters of mercury. And if it's over 30, then that is an emergent situation, in which case they'll probably end up doing a fasciotomy to open that up and actually start to relieve some of those pressures. So traumatic and non-traumatic causes, as we've talked about, everybody always thinks about these being an entrapment, not necessarily always the case, as I've mentioned. So the way that we know this is the 6 P's of compartment syndrome. So you have what is the 6 P's are pain, poikilothermia, pallor, paresthesia, pulselessness, and paralysis. So we all know pain. And one thing that I would like to mention here, if you're an EMT and getting ready to go to paramedic school, or you're in paramedic school, one of the things with pain is it will be pain that is disproportionate to what you are seeing. So you're looking at the extremity and you're like, why is this person freaking out and saying that there is so much pain? There's nothing wrong. There's nothing that we can see. So that pain is an extreme pain, and it's all because of the pressure on the inside that we just simply cannot see. So anytime you would read or see anything that says pain that is disproportionate or pain that doesn't fit what you're seeing, they're probably trying to get you down the path of a compartment syndrome. Poikilothermia is at the extremity at room temperature. It basically loses its ability to vasodilate and vasoconstrict the way that it should. So it ends up becoming just room temperature. If it's cold in the room, the extremity is going to be cold. If it's warm in the room, it will hold that temperature. Pallor, we understand, just pale. Paresthesia, kind of pins and needles. You have that tingling sensation, pulselessness, and then paralysis. Obviously, they're not going to be able to move it eventually. So traumatic asphyxia is a little bit different. It's a sudden compression, and most of the time this is obviously going to be caused by trauma. An object like this that has fallen and is now compressing the chest cavity. When that gets compressed, the pressure starts to build up, and then you end up getting an engorgement of blood vessels in the shoulders, neck, face, and head. So all of those areas above the heart, they don't have the ability to return through that superior vena cava. So all that blood flow is there, and these patients are pretty identifiable. Oftentimes they might have ruptured blood vessels in their eyes, and they'll have outward signs that you're going to be able to look at and figure out that this was a traumatic asphyxiation. They're going to be discolored, meaning bluish, and have ruptured vessels above the level of the heart. So increased intrathoracic pressure, a Valsalva maneuver plus crush injury ends up being a cardiac phenomenon more than a respiratory phenomenon. So the heart ends up shutting down. It's not able to pump. They probably also have depending on where the injury has hit, they may also have a cardiac tamponade, in which case we're not necessarily able to relieve that. But the bottom line, they're probably not going to survive this injury anyway. Even if we had the ability to do a pericardiocentesis, the patient's probably not going to come back from this if it's truly a traumatic asphyxiation situation. So here again, kind of how the patient looks, you can see that they're discolored. The face is definitely a discolored situation. So he's got jugular venous distension. That's a backup of the pressure from that superior vena cava because it can't pump out through the normal mechanism. Bulging eyes, and they'll get that subconjunctival hemorrhaging. So all those blood vessels in their eyes are now starting to rupture, and then purplish discoloration above the site. If you see that, think of a traumatic asphyxiation. If you also see that, but they don't have a trauma history, these are the patients where we think that maybe it was more along the lines of a pulmonary embolus. And if you think about it, it's kind of the same thing, just through a different mechanism. A pulmonary embolus is obviously something that has lodged in the pulmonary artery, and then things back up into that right ventricle, go up through the tricuspid valve into the right atria, and then up to the superior vena cava. So they end up getting jugular venous distension, et cetera. It's just more of a late sign. So same findings, different mechanism. Engorgement of the tongue and the lips. And then they may have myocardial or pulmonary contusions and tension hemathoraces that are also found with that. What I would tell you is follow your protocol. Myocardial contusions, they will end up causing the patients to have ectopy. These are not patients that I would recommend that you treat with antiarrhythmics. So just because they're having a bunch of PVCs or something doesn't mean that they need antiarrhythmics. But if you want to do that, I would definitely call before you decide that you're going to do that because it's not necessarily appropriate medical treatment. So what are we going to do for it? Well, The management really is supportive. High flow oxygen is really all that we're going to be able to do. Obviously, remove the pressure as quickly as we're able to do that, get IV access, and then aggressive ventilatory support if indicated. These patients may end up having to be placed on a mechanical ventilator, and they may have to have high pressures to overcome some of the damage that has been done. Crush syndrome, as we talked, is a collection of symptoms. So it's significant systemic symptoms that result from a toxin released because they have had some sort of a crushing injury to the muscles. So if we have pressure that is exerted onto the muscles for a long period of time, there are toxins inside of that, and they get released. And there are proteins or a bunch of different things, but myoglobin is one of the things that is held inside of your muscles. And when they are damaged, they end up getting released, and then the patient ends up with a myoglobinemia, which we're not going to know in the field, but we're certainly able to understand that the patient has had a crush syndrome, and there are some things that we can do to try to help benefit the patient in the long term. So 40% of multi-story building collapse victims experience a crush syndrome. So if they're involved in any type of multi-story building collapse, again, not something that happens all the time, but you can see if they're in any of these situations where this type of trauma has occurred to them, that they're at an increased risk. And then what ends up happening is those toxins are released into the bloodstream, and then it ends up circulating around. And once it gets to the kidney and the heart, it's going to end up causing some other issues. So they may end up having some renal insufficiency and renal failure. And then they may also end up having some cardiac disturbances. So we're going to talk about what we should do for those situations. So how long does it take? Really, it only takes about an hour for those toxins to build up to the point where it is going to become a problem for us. And if you think about it, I mean, again, just here regionally, if you had a subject that was, entrapped in some sort of a ditch, and the first responders get there, regardless of whatever department it is, you're probably going to call for a technical rescue. By the time technical rescue even responds there, you're at an hour. And that's not anything negative towards TRT, but by the time they truly have the dispatch and respond and get a team together and get people there, I mean, you're probably in an hour from the onset of injury. This patient is already starting to develop some of these crush syndromes, and the myoglobin is already being released. So what ends up happening here is they have a direct mechanical injury, and then sodium and calcium is released with an influx of water. So they end up on the inside of the vessels, the intravascular space, they lose volume. And that is what causes them to become hypotensive. So the inside of the cells are empty, or depleting, or they're starting to become depleted. So the patient will become hypotensive from that. And then it becomes a cyclical thing. So once they are hypotensive, they become hypoxic, they don't have the cardiac output, so they end up turning into an anaerobic metabolism, and that is where we get our lactic and pyruvic acid buildup. And then we come along, or the TRT comes along, and we pull that pressure off, and now all those toxins that have been building up are released systemically, and that is where the problem comes in. The two big things that we are worried about is potassium and myoglobin. The potassium and myoglobin, they're both in the cells, but the myoglobin is in the muscle as well. And when we release that pressure, that myoglobin that has been released from those damaged cells and damaged muscles are going to start circulating around, and that's what's going to end up hitting the kidneys. So this is directly from the Southwest Ohio, Northern Kentucky protocols. While attempting to extricate, so this is actually broken down into a couple different areas. It's while attempting to extricate, and then prolonged extrication, and then what we should do after they are extricated. And the treatment is going to be a little bit different based on which stage you are in during this extrication. So clearly get the patient out as quickly and as safely as we can. I think that goes without being said. We need to maintain the patient's airway and ventilation status and get all of the area around the chest free as much as possible. In a car wreck, that may not be necessarily a possible thing to do, but if you're able to move some metal, or move some dirt, whatever it is that is causing their problems. Try to get as much of it from around the chest as you can. We obviously have to control bleeding at this time. And then we want to coordinate with the rescue team for the administration of an oxygen or a nebulizer if it can be done without it creating a dangerous atmosphere. So we want to make sure that they're not using any type of cutting torch or anything like that. And that's why they're saying dangerous atmosphere. Initial bolus of 1 to 2 liters of crystalloids would be appropriate. And then we want to monitor their EKG. What we're looking for here is a bump in their potassium showing hyperkalemia, and we'll know that with tall tinted T waves on our EKG. And then we can give them some pain management medications as well. So if it is a prolonged extrication, they're in there for greater than 60 minutes because now we're worried about them building up some of that myoglobin and some of the other acids that are going to be a problem. We're going to give them an amp of sodium bicarb, and we mix that in 1 liter of crystalloids, and we're going to do that 1 to 2 liters an hour. So this is not something that you're just going to push an amp of bicarb. You're going to take your bicarb, you're going to put it in a liter of fluid, and then you're going to infuse that through your IV over an hour, 1 to 2 liters over an hour. This is a dedicated bicarb line. And remember, this is not something that like they're doing out west and we're just recommending. This is in protocol. So if you guys in Northern Kentucky or regionally here have a situation where this were to occur today, this is what you would be expected to do. So make sure that you have a line in. This becomes your dedicated bicarb line at this time. And if a second line is unavailable, if you can get another line, that's great. But you should only be using sodium bicarb through this initial line. If you get a second line, that's fine. You can use it for fluids or anything else that you need to administer. But if you're not able to do that and the patient needs pain medications, which they probably will, then think about giving them either an intramuscular or an intranasal medication. So with your, actually, hold on one second. I want to go back and make sure my screen's jumping around here. When you're doing your pain medications, think about the different pain medications that we carry and how much of the medication you could give. So under the pain management protocol, fentanyl 25 to 100 mics. And obviously we can titrate that and we can go up, but we're going to do that about every 5 minutes if we have given that through an IV or an IO. If it is an intramuscular or a sub-Q injection of any of these pain medications, and you really need to wait 15 minutes because we don't know how well that is going to absorb. The last thing that we would want to do is give this medication. Remember, they're already hypotensive, so we know that they're dropping their pressure. And when their pressure's dropped, they're not able to absorb that medication like they should. So hypothetically, we give them, 100 of fentanyl and we give that IM, and then 5 minutes later, 7 minutes later, the patient's like, I'm still in pain, and we give it to them again, and then all of a sudden it gets absorbed. Well, now we have a problem. We probably overdosed our patient. So 25 to 50 micrograms, and you can do that either IV, intraosseous, intranasal, intramuscular, or sub-Q, and you're going to repeat that every 5 minutes if needed. Or you can do it every 15 minutes if you have given that through an IM or a sub-Q. If you are still using morphine, it would be 2 to 10 milligrams, and it's the same concept. If you've given that IM or sub-Q, then I would wait 15 minutes, and the protocol says to wait 15 minutes prior to re-administering your morphine. But fentanyl and morphine are both appropriate in this situation. So what do we do immediately prior to extricating the patient? Well, we're going to apply tourniquets to the trapped extremities. We want to try to slow that those acids and that myoglobin from circulating around as best we can. And now is when we are going to give our bolus. So give a milliequivalent per kilo of sodium bicarb. That dose should be easily enough for you to remember because it's the same dose that we give for everything else. It's also the same dose that we give our pediatric patients. So it's 1 milliequivalent per kilo, but that is literally when the rescue team says, hey, we're getting ready to remove this. Are you ready to go? Yes. Now give your sodium bicarb, and you should be pushing that through that pre-established bicarb line that is the only thing that you're using it for. All right. Immediately following the extrication, now you need to prepare the patient for some problems and complications with hyperkalemia. Remember, hyperkalemia is going to end up causing the patient to have some dysrhythmias and maybe even potentially cardiac arrest. So we need to be prepared for that. There are a couple different medications that we have available to us that we can talk about. But they should ultimately obviously be transported to a trauma center first and foremost because of their crush or their pressure system. If they're going to end up needing to have a fasciotomy done, trauma center will be the most appropriate. And then you can consider releasing tourniquets only after you have talked to either online or on-scene medical control. So if air care's there, that would be appropriate. Let them kind of take control of that and they can do what they need to do. If you do not have somebody on the scene that kind of outranks you medically, then I would call in and talk to your base physician to find out what they want you to do. With hyperkalemia, what we're looking for here is their potassium level to spike. Remember that you have sodium, potassium, and the potassium is going to end up finding its way into the bloodstream. So it should not be in the bloodstream. It should not be an intravascular finding. It should be an extracellular, like a cellular finding. So once that potassium makes its way into the bloodstream, now our blood potassium level peaks. We're not going to know that, because there's no way for us, unless you have an iStat or something, there's no way for us to know this in the field other than looking at their EKG. So hyperkalemia, just high potassium, and the normal potassium, these numbers are off a little bit. We just did a 12-lead thing and I talked about this and that. Look at the reference range for the machine or the lab that you are using. So under normal conditions, I would say that a normal potassium is 3.5 to 5. Yes, certainly there's a lab out there that's 3.6 to 5.2. What you need to figure out is what the lab range is, because what lab A is and what lab B is might be two totally different things. So if we know what our potassium is and they are hyperkalemic, then that would be fine. So the situation there, maybe you're going to do a transfer. You get called to the ER to do a transfer, especially if this House Bill 505 thing goes through. They may have labs available for you. Hey, we've done this potassium, it's a crush injury, and the patient's potassium is 6 or 7 or whatever it is. Anything over that 5.5 is going to be considered hyperkalemic, and that is based on whatever the lab finding is. If you look here in the center column, the typical ECG appearance, if they have a potassium finding of somewhere around 5.5 to 6.5, you're going to end up getting these tall peaked T waves. All right. And you may have a prolonged PR segment. This PR interval is going to get longer, and then they're going to end up having a tall peak T wave. And that's what we all learned about in basic education from paramedicine. Once that potassium gets a little bit higher and it's over 6.5 up to about 8, now you're going to end up losing the P wave. They're getting ready to go into a more ventricular rhythm, i.e. ventricular tachycardia pulseless or ventricular fibrillation. So they have lost their P wave. That QRS starts to actually prolong or elongate. And now you may actually start to see some ST segment elevation. And then once it gets over 8, they're going to end up getting something called a sine wave maybe, and that is actually where it just kind of goes up and down, up and down. It would kind of look like this if this was just continued across the rest of the page. That is leading towards ventricular fibrillation. We have got to try to fix that early, and we should be fixing it up here in this mild situation. So a couple of different ways that we can try to do that to get their potassium levels back down. We can give them a couple of different medications. Calcium gluconate, a gram, either IV or IO. And I'm going to talk about how all of these work. You can do that sodium bicarb. So sodium bicarb, we're able to do a couple different things using sodium bicarb, and then albuterol and duoneb. So all of these, they work through different mechanisms, but it's all the same exact process. So why do we do calcium? Well, calcium is always the antidote to potassium. So if I have high potassium, I want to give calcium. If I have high calcium, I want to give potassium. They're always going to be opposite of one another. The thought is that calcium, a lot of people think that calcium actually lowers the potassium. It does not. What it does is it puts the potassium back where it's supposed to be. It puts it back into the extracellular component, and it is not floating around in the blood. So calcium will help to open up some different channels to get the potassium to switch and get back to where it's supposed to be. Sodium bicarbonate kind of works through the same type of mechanism, but it does a bunch of different things, actually. Sodium bicarb is really an interesting drug. I'm not going to go into depth on it, but if you guys are interested and you want to look it up, you can look up, it's called the Henderson-Hasselbalch equation. And that's basically how sodium bicarb works. Essentially what happens here is it takes your HCO3 negative, which is bicarb, and it turns it into carbonic acid, and then you blow off your CO2 and you pee off your water. And that's kind of what's happening here, is it's taking those hydrogen ions and it's making the potassium get back into the cells where it's supposed to be. And then albuterol and duoneb is the same concept. So we know that we use albuterol and duoneb when patients have asthma, emphysema, those types of things, and it works on the beta-2 receptor sites. Well, same thing here. The albuterol and duoneb will work on those the beta-2 receptor sites, and it helps to pull the potassium back into the cells. So 3 different drugs, 3 different mechanisms, but they're all doing the same thing at the end of the day. So if you have a crush injury, you have somebody that is hyperkalemic, don't be surprised when you call in if the physician on the other end asks you to go ahead and start them on either an albuterol or a duoneb treatment. And that's why at the very beginning of this portion, when we talked about having conversation with your rescue team to make sure that they are ready and you are ready, it said place the patient on oxygen and a nebulizer. Well, some of you may have caught the nebulizer and thought, why would you do that for a crush injury? Well, this is why. So if they are crushed, albuterol or duoneb will work on the receptor sites at the beta-2 to help get some of that potassium to shift back where it's supposed to be and lower their potassium. So bicarb and calcium gluconate, they will particulate if they are used in the same line. Actually, bicarb really with anything. So don't use other medications through your dedicated bicarb line. If you have to, make sure that you flush, but we really should not use it. And based on protocol, we should have a dedicated line. All right, we'll end up here with rhabdo, just a couple more minutes, and then we will call it a day. So rhabdo, the clinical symptom here is when skeletal muscles are injured and they release something, part of their intracellular components, into the extracellular fluid. So these are things that should be on the inside of the cells. And when those skeletal muscles are injured, it releases them. And what it is releasing is myoglobin. So some of these can be reversible, others are irreversible. And if it is bad enough, it will end up leading to renal failure and then a subsequent death. So this is not something that we should take lightly or that we should be playing around with. This is something that can happen to us. We have to pay attention. For you training people out there, if you are doing trainings and it is hot out and you're doing evolution after evolution, you've got to give people breaks. You got to make sure that people have enough time to have water. If you are a coach, maybe you coach your kids' football team or baseball team or something like that, and you're doing conditioning and running. So who is at a high risk for having rhabdo? People that are really active. So the military, athletes, and people have gotten more aware of these conditions and the rhabdomyolysis because of situations that have occurred in the military and in the situation where they are in different types of trainings for athletics or whatever. So it is identified using something called creatine kinase or CK and other clinical indicators. And then basically what happens is all of that tissue starts to break down and they end up getting this myoglobinuria, which is myoglobin in the urine. So they'll get it in the blood, myoglobinemia, and then myoglobinuria, which is just the myoglobin that spills over into the blood, and they can figure that out with some urine testing. A bunch of different causes to this. Like we could spend an 8-hour day talking about the causes of rhabdo. Alcohol, cocaine, and narcotics excessive physical activity and toxic ingestions. But there are other things that I think that you guys need to be aware of that will cause this. And a lot of these are prescription medications. Some of the most common prescription medications that cause them are your statin type medications. So individuals that have high cholesterol, which like, 25-ish%, something like that, about 25% of the patient population is on a statin medication. So if you have high cholesterol and you're on Lipitor or Crestor or anything like that, just by being on that medication, you're at an increased risk for having rhabdo. So you can see, I'm not going to read the entire list to you, but Elavil or amitriptyline, Prozac is another one, Haldol, Phenergan, and then we get into some of the other ones that are very common, diphenhydramine, and then some of your other ones that are illicit medications like heroin and cocaine, those types of things. So there are a bunch of different medications out there that can cause rhabdo. So complications here, acute complications of rhabdo, acute kidney injury, and you can see all of these different things. You can end up getting disseminated intravascular coagulopathy, which is a late finding. We've talked about that before. That is a clotting issue. So they're not able to clot appropriately. They can get compartment syndrome, hypovolemia, hyperkalemia. What will we do for high calcium? Well, you would want to end up lowering that. They probably would give them potassium. What about low calcium? Well, you treat low calcium with calcium. There's hyperphosphatemia and then hyperkalemia. So all of their electrolytes are going to be off, which tells me that they're going to have a lot of complications and some cardiac disturbances. How are we going to know it in the field? Well, we're going to have to figure that out through clinical presentation. First of all, signs and symptoms. What has been going on with that individual to lead them into rhabdo? If this patient has been just sitting in their recliner at home and they're not on any meds and they don't have any medical history, probably not in rhabdo. If they're on some of these medications that we've talked about, or you pick them up from boot camp or a football field or something like that on a hot summer day, then you probably should be thinking about rhabdo at least being in your differentials. So they may have fever, confusion, or a change in their level of responsiveness, abnormal or irregular heartbeats, and this is probably related directly to the electrolyte abnormalities that they're having, nausea and vomiting, dark colored urine. So if, we don't typically check urine in the field, but if they do have either a folic cath or they have urinated or they give you that history that their urine is like tea colored or it looks like a cola, a dark colored cola, then you need to be thinking about rhabdo. Muscle swelling and then inability to move arms or lift objects, and that's because of the muscle breakdown. It's not that they don't have any muscle there, but the electrolytes are in the wrong spot. So they're not going to contract and assist with the movement of muscle like they should do under normal conditions. So the treatment specifically for rhabdo, it may be caused by a crushing injury as described previously, or it can be from these other etiologies that we've just talked about. Essentially, what we're going to do here is going to either an IV or an IO, and it's going to be 1 to 2 liters of a crystalloid solution. So for most of us, we're going to use sodium chloride, normal saline to prevent renal injury. You want to try to be as protective of the kidneys as you possibly can, and then we're going to monitor for hyperkalemia. If we have hyperkalemia, you're going to go to the other protocol and either think about calcium gluconate, sodium bicarb, or your albuterol doing a type treatment. Any questions? That is a lot of information. Here is the references that were used for today's talk.